Okay, welcome to EDUSM. Now approach to altered mental states. Okay, what are the things that you want to do? Basically, you want to address easily reversible causes like hypoxemia, hypercarbia, and hypoglycemia. The next thing is you want to differentiate structural causes from toxic metabolic causes. Because for the first one, you need to do emergency CNS imaging or CT scans. And for the later ones, you need to do laboratory studies. If you're outside of the hospital, you should consider treatable or reversible causes of AMS, for example, hypoglycemia, which you can treat with dextrose 50%, or hypoxemia by giving oxygen, or even heat stroke. So before you send the patient, you can do the cooling measures. As for the management, patient should be managed in the critical area. You may transfer to intermediate area once you find out the reversible causes. Okay, consider positive pressure ventilation as well as cervical spine immobilization, especially if you suspect trauma, and consider oropharyngeal and nasopharyngeal airway. Consider cervical collar and manual inline stabilization, especially if you could not exclude trauma. You should consider definitive airway management in a comatose patient. You can do intubation with or without RSI, and you may also consider surgical airway management if indicated. Okay, approach to altered mental state. In summary, you assess ABC and do resuscitation, and then you assess the vital signs. You do the ECG monitoring and perform bedside glucose. The next thing is you do targeted history and physical examination. You look hard for head injury, neck stiffness, respiratory rate, and pupil size, and you look for focal neurological signs. And is there any evidence of chronic organ failure signs? Then you start to look for the causes. I would normally divide the causes into two: structural causes and toxic metabolic causes. For the structural causes, establish whether there is head trauma or non-head trauma. For the head trauma, think of intracranial hemorrhage. For the non-head trauma, think of intracerebral hemorrhage, subarachnoid hemorrhage, brain stem stroke, cerebellar stroke, and a cerebral tumor. For the toxic metabolic causes, you can divide it into febrile and afebrile causes. For the febrile, think of cerebral abscess, meningitis, encephalitis, cerebral malaria, bacteremia, septicemia, and even UTI in elderly. And don't forget about heat stroke. Now for the afebrile causes, think of poisons like a drug overdose, alcohol intoxications, wernicke's encephalopathy, and carbon monoxide. Then we look for metabolic causes like hypoglycemia, cerebral hypoperfusion, hypercarbia, TKA, hypothermia, dehydration, electrolyte, and acid-base abnormalities. The next thing is organ failure. Look hard for uremia, hepatic, respiratory, and cardiac failure. Patient may also present post-ictal state, and we tend to neglect psychiatric causes like psychogenic stupor and dementia. And now for some important notes. For the structural causes, usually they have focal neurological signs. For the toxic and metabolic causes, they do not. Subarachnoid hemorrhage usually does not have focal neurological deficits, and SAH and some of the toxic metabolic causes may have fever. Number 2, for the psychogenic stupor, what is it actually? It's a dissociative state where the patient looks conscious but it makes no spontaneous movement, and if you try to stimulate the patient, there is very little response to external stimuli. It is caused by a major stressful event and the onset is sudden, and you probably would see flickering of the eyelids. But remember, this is a diagnosis of exclusion.